Hello, guys. We have so much to go through in this one. This is going to be heavy, 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 but we're going to talk about how different parts of the body can be affected by different traumas. So, we're going to predict and prioritize the care for patients with head and neck, chest, abdomen, and pelvic, and some certain orthopedic traumas. Just once again, trauma can be defined as that injury that results from energy transferred from the environment into that human tissue, and various ways that this could occur. Let you guys read this one on your own time, but just take from this slide that there's various ways we can achieve a trauma. And some of these can be predictable, so that's why we put safety features in place, and it can be very, very costly. And nurses should always be advocates for their safety equipment. In this case, they're highlighting that helmet, which, the joke is if they fell, I don't know what a helmet would do for these people, but there you go. Okay, we're going to get right into some traumatic brain injuries. Epidemiology, once again, this is very cost prohibitive. It costs $60 billion a year in the United States to aid in these traumatic brain injuries, and lots of various deaths and permanent disabilities can occur. Falls account for about half of them and are old and are young. In fact, are very young, are ages 0 through 4, as you can see the risk factors in this slide. Our kids with the big heads and unsteady gaits and exploration tendencies tend to be at risk for the traumatic brain injury, as well as our 15 to 24-year-olds that don't quite have that prefrontal cortex going on, and can be a little bit of risk takers. They're also, brand new drivers and, are involved in much more sports. So traumatic brain injuries, we can have our blunt or our penetrating traumas, and other various risk factors include substance abuse, anticoagulation, and once again, highlighting that improper safety device use there, or lack of safety devices there. And we can get that primary and secondary damage from our traumatic brain injuries. So our primary happens at the time of the injury, and secondary would be the sequela due to this primary injury. So our primary injuries can include our scalp lacerations, fractures, cerebral contusions, cerebral lacerations, intracranial hemorrhages, diffuse axonal injuries, and our secondary damage can occur. Mostly vascular and neuro, with some, immunology there. So we can have ischemias and hypoxias, some cerebral swelling, infection, hypercarbia. If we think about what that brain does, controlling the autonomic nervous system, and a lot of these are easy to guess, right? We can also get our seizures, hypoglycemia, and hypotension. Nothing quite like beating a dead horse, but since you've seen a slide or two of these, you should probably know what the Glasgow-Coma scale is. As if you remember, we have our saying in the emergency department that says if they're less than 8, we intubate, which means if they're less than 8, we can't really predict how they are going to control their secretions or aid in their own breathing, so we need to help them, assist them with their breathing there. But what if a patient comes in and they are already intubated? The Glasgow-Coma scale is not going to do so good. So beyond that, AVPU score that we learned last lecture, we could use the 4 score, full outline of unresponsiveness score. And as you can see here, this takes into account or considers the intubated patient. And so we can still do some neuro checks on these patients even while they are intubated. quick review of our brain here, or, various features of our skull. As you can see here, we have these like superficial veins, bridging veins there. We have most of our vasculature, which is going to be in that dura mater area. Then we have our subdural space, followed by our subarachnoid space, and then pia mater. So consider those when you consider our brain injuries here. Here's one type of injury that we can have, which I'm sure you learned about in neuro. This is called the contre-coup type injury, which basically says that we are going to hit one solid object, using those laws of energy. And then because our brain doesn't make up the entire space of our skull, it's going to cause this pressure wave that travels back, or the opposite side of the injury, and create a completely different injury on the opposite side of the damage. Signs and symptoms of this one can include an altered level of consciousness, behavioral, motor, or speech deficits, abnormal motor posturing, or any signs of ICP. Now we have our cerebral contusion. This is our big bruise, right? This often occurs in the frontal and temporal lobes, where we're, most often likely to hit something. And it is a damage of capillaries, which results in hemorrhage. So those smaller little veins and capillaries there. And it can be quite troublesome. It can lead to infarction, necrosis, edema, and even significant contusions may cause those midline shifts, which, as you guys know, can lead to quite poor prognosis for the patient. Maximum effects typically peak at 18 to 36 hours after injuring. So let's say a patient had a head injury. They have a 13 through 15 Glasgow Coma scale, so we're not going to automatically CT them. I'll talk about that in a different slide. But we are going to send them home with a responsible person who could watch them for up to 36 hours, because things like this can kind of manifest, and we should be aware of any kind of alterations in the level of consciousness following any kind of injury. Now we have our intracerebral hematoma, and these are, cause quite significant damage. This is that injury that occurs deep within that brain tissue, oftentimes associated with skull fractures and cerebral contusions, big injuries associated with this, and it can create a significant mass effect. I'll talk more about that on the next slide. Signs and symptoms of this are progressive and often rapid decline in LOC for these patients. So it doesn't take long to figure out, that we need to get them into imaging right away. And then we have our headache, signs of increased ICP, pupil abnormalities are likely, and then contralateral, so other side of injury, right? Hemoparesis or hemiplegia, so numbness, tingling, or motor difficulties, or you might even see some motor posturing. So here's this mass effect. It is officially called the Monro-Kelly hypothesis, which basically means that we only really have enough volume in our head for, what should be there. As you can see here, we have some venous volume that takes up a large amount of our volume in our head there, as well as our cerebral spinal fluid. And then, obviously our brain, and then some arterial volume. Well, when a mass occurs, we start making way for the mass by losing some venous volume and cerebral spinal fluid. And as you can see, the bigger the mass, the more detrimental that volume status is going to be for them. All right, quickly talk about epidural hematomas versus subdural hematomas. As you can see on this slide, one involves arteries, which, as we know, have a lot of pressure, a lot more, blood. They're bigger, right? And so they can cause that quicker damage. So epidural hematoma equals arterial bleed. Subdural hematoma, this usually occurs from a torn bridging vein. And as you can see on this slide, because it's venous, it tends to bleed quite slowly. Okay, so this slide demonstrates the epidural hematoma versus subdural hematoma a little bit more. Epidural hematomas are likely to involve fractures, just like in the last slide, in the temporal or the parietal bone. So high level of suspicion when we injure that temporal or parietal bone, especially with our open fractures there of epidural hematoma. And 90% of them lacerate that middle meningeal artery, something you should know. This is actually characterized by loss of consciousness immediately, followed by a lucid period, and this can last minutes to hours. So we may assume that that patient is out of the woods in this time, but really there's a rapid deterioration after that, and the outcomes are pretty poor if they don't act quickly on these. The patient might have extension posturing associated with a brainstem hernia, and obviously we know that that is associated with poor outcomes for this patient. Definitive treatment for epidural hematoma would be our immediate surgery. And then we have these subdural hematomas of the veins, right, caused by a slow collection of blood beneath the dura mater. And it can be caused by an acceleration, deceleration, or combination of an acceleration or deceleration force, aka shearing, where we get that torn bridging vein. These can be acute or chronic, and the acute ones, here, listen to this, acute ones will manifest within 72 hours. So as you can see, these are awful slow growing. Chronic is associated with minor injuries, or the chronic ones associated with minor injuries can be exacerbated by anticoagulant use, advanced age, or alcohol use, and they occur slowly. This says may take to 2 weeks to manifest symptoms. Sometimes it takes even longer to kind of figure out what's going on. It's not unusual for a patient to come into the emergency department with, a somewhat altered level of consciousness, headache and some fatigue. And, when it comes down to it, they've had a head injury like a month ago. So these can be awful slow manifestations. Won't go too much into this slide as you did this in your neuro lectures, but we can obviously have herniations of various natures in our brain there. Signs and symptoms of these include asymmetry of that pupil reactivity, unilateral or bilateral pupillary dilation, some abnormal motor posturing, or changes in LOC or even paralysis. Okay, so as far as traumatic brain injuries go, the concussion is considered that mild form of traumatic brain injury, and that's where our Glasgow Coma Scale, or GCS, remains between 13 and 15, and there is a mild or transient change in the level of consciousness. The patient still does have neurofunctioning, and when we do a CT scan, there will be no changes. So that makes the concussion a diagnosis of exclusion. So it's a diagnosis based on the patient's symptoms, not what we'll see on the neuroinjury there, or imaging. And then obviously our traumatic brain injuries can go into that mild and then severe forms there. So a little bit more on concussion. This is a mild diffuse brain injury. There's no CT findings, just like I had said. 20% of concussions are in the age groups of 19 and younger. And the GCS score within 30 minutes will be 13 through 15. The patient may exhibit symptoms of confusion and disorientation. They might have a headache and fatigue. They may have poor concentration, even some personality changes is what has been described. They may have anxiety, irritability, and for the next 24 hours, they may exhibit some amnesia following the trauma, so may wake up the next day and not really remember much of the day before. Patient might also exhibit signs of photophobia and phonophobia, or, the irritation of light and sound, and they may have some nausea or vomiting. I myself have had a pretty good sized concussion, and the nausea and vomiting was something I can attest to. Return to play is slow and gradual, and therefore is usually mandated by the state. And that's because, or various states, I think, there's somewhere around 34 of the 50 states in the United States have traumatic brain injury or concussion type protocols that their schools have to follow. So it usually looks like, patient comes in exhibiting signs and symptoms of a concussion, but they happen to be like the star quarterback, and this is the game right before the finals, and they really have a lot of pressure to come back to play there, but something significant can happen, and that's called the second impact syndrome. This occurs when the brain swells rapidly and catastrophically, and that's after a person suffers a second concussion before the symptoms from an earlier concussion have subsided. The second blow can occur minutes, days, or even weeks after initial concussion if that initial one hadn't subsided, right? And even the mildest grade of concussion can lead to that second impact syndrome. The condition is often fatal, and almost everyone who's not killed is severely disabled. So something that we should pay very close attention to, and it doesn't get resolved in the emergency department. They cannot return to play until their provider has said that they could. So how that usually looks then is once they exhibit no signs, with no activity, then they can go to light aerobic exercise for 24 hours. If they still have no signs, they can go, to a sport-specific type exercise, and then contact, and then we can do full contact. So it is a process. I won't go too much into this because one of your peers will be talking about the CT criteria for a traumatic brain injury or concussion. Not everybody gets radiation from a CT scan. We try not to do that, so we only will do a CT scan if they exhibit signs within whatever protocol we choose to use. And oftentimes we do use that Canadian CT head rule, or the ACEP, the American College of Emergency Physicians, clinical policy on CT scan criteria for the mild traumatic brain injuries there. And if they have enough, points based on whatever you're seeing here, then they'll get the CT scan. A couple of things you need to know about a penetrating head injury. I mean, obviously it's obvious what happened here. There was a knife into the head, and this does look like a child based on all those little teeth up there. But when you are a nurse and you see a penetrating trauma, you should not attempt to take that out for fear of some vascular instability there. So you want to leave that penetrating object in place and then stabilize, and that can include, wedges taped around it, something, that'll stabilize that without moving it. And then obviously you're going to prepare that patient for transport to a hospital that has the capability of neurosurgery, or upstairs if your hospital has that. Go into some skull fractures. We've got our linear or non-displaced fractures, our depressed fractures, and then our basilar fractures. Our linear is going to be non-displaced of any part of the cranium there, and it's just usually typically something we watch and wait unless there's something underlying going on. Assessment findings of this: we have our headaches, surrounding tissue injuries, and possible decreased level of consciousness for these patients. Then we have our depressed skull fracture, and you can actually put your hand in there and feel the depression of the skull. The assessment findings for these guys is going to be, obviously a little bit more severe. They will have headache, surrounding tissue injury, and a palpable depression of the skull over the fracture site. You might also see an open fracture associated with this, and even decreased level of consciousness. That goes without saying. Then our basilar skull fracture. This is going to be our fractures in the base of the skull here. Their assessment findings are quite unique for this, and they can include this periorbital ecchymosis. They call that raccoon eyes. That's at the top of your screen there, top right, and then, the bottom right there. They call that one mastoid ecchymosis, or also know that as battle signs. The patient may also exhibit signs of a headache, altered level of consciousness, rhinorrhea or otorrhea, and that's where we're getting cerebral spinal leaking from our nose or our ears, right? And one way to tell is if we have, our gauze laying down and that leaking fluid kind of creates that yellowish halo, we can predict that might be cerebral spinal fluid. But way back in the day, they used to be able to just do a glucose check because, our snot doesn't have glucose, but our cerebral spinal fluid does. That would be a quick and easy way to do that as well. The patient might also have some facial nerve palsy from this if the cranial nerve number 7 or facial nerve is impacted. And then we have our maxillary fractures, and these are known as Lefort 1, Lefort 2, and Lefort 3. As you can see, they go up in gradation there. So our Lefort 1 is going to be just that transverse maxillary bone that we have a fracture, so you may see some swelling of that maxillary area, lip laceration, or even some fractured teeth there. And you might see edema or malocclusion, so the setting in your mouth is for your teeth is not right. Lefort 2, as you can see, is a pyramidal, and it includes the maxillary bone involving the mid-face area. The apex of the fracture transverses the bridge of the nose, and there's lots of our smaller bones that can be included with this, like our orbital bones and stuff like that. Assessment findings of this one, you're going to have quite a bit of facial edema. You might notice some nasal swelling with a fracture to the nasal bones, malocclusion, once again on that, and then some cerebral spinal fluid rhinorrhea there. And then our Lefort 3 is going to be a complete craniofacial separation. Involves lots of structures, so our maxilla, or zygoma, orbits, bones of the cranial base, and assessment findings for these guys are going to be like lots of facial edema, mobility, and depression of the zygomatic bones. So you could feel for mobility or depression. Ecchymosis, CSF, rhinorrhea, and diplopia can happen because of a nerve entrapment at the fracture site, so you might be able to see, double vision. And with these, they might have an open bite or malocclusion. Mandibular fracture or jaw fractures, these can be quite interesting because they look so very painful, but usually when they have this, they have a lot of anesthesia there to the lower lip, and even, within that mandibular area, so the patient may not be as upset about it as you think they should be, I should say. Some clinical features of this, they might have the inability to open their mouth. There's definitely going to be lots of drooling. So with these patients, I always have them sit up and forward so they're not having any kind of aspiration. That we also want to manage their secretion. So whether we are suctioning them or we have taught them how to suction their own secretions, we need to be managing their secretions in some form or another. The patient will have facial asymmetry, edema or a hematoma, and potentially a ruptured tympanic membrane. So if you can see in there, that pearly gray area in the back there, just try to look at ears, because then you can see what a bad one looks like. You're not going to have that tympanic membrane. And then, like I had said, anesthesia of the lower lip. And then, the patient is going to have to go to surgery and get their jaw wired back together. So nursing care for all of our traumatic brain injuries is going to be to maintain that SpO2 greater than 95%. Note that one single episode of lower SpO2 has been known to cause problems for the patient. And then once again, we don't hyperoxygenate the patient as well. So 95 to 98 would be a good solid goal for these guys. We're going to avoid hypotension, especially in those that are greater than 65. And this is included in all traumas for our elderly patients especially. We're willing to tolerate quite a high blood pressure because low blood pressures can lead to poor outcomes. We might have to infuse them with warm crystalloids or blood product if they're in a hypovolemic state. We're going to monitor ICP. We're going to perform visual acuity tests if any structures of the eye or brain are damaged in any way. We use a visual acuity test often. So have that Snellen chart available, or whatever your emergency department or hospital provide. And then we use the Tonopin as ordered. Remember, anything greater than 20 millimeters of mercury indicate that there's a problem with too much pressure there. We're going to complete a neuro exam, and not just one. We're going to do serial neuro exams, usually upwards of every 15 minutes. And in some cases, we're going to do them even more frequently than that for our high acuity patients. We're going to consider that advanced airway quite early, and this also has to do with being able to control ventilation. So hyperventilation is something that we will oftentimes do. If there's any kind of sign of herniation, that's going to decrease that pressure in the brain. And so sometimes we just do an airway so we can manipulate the ventilation portion of that. Patient obviously remains at a one-to-one nursing care. We're going to monitor vital signs, pay close attention to the blood pressure, the respirations. Head a bed at a 30-degree angle. If the patient is in a C-collar, we can put them in a Trendelenburg kind of state, so we can kind of keep their C-spine maintained while elevating that head of the bed there to optimize the ICP. And then we might use reversal coagulation medicine. We might give mannitol. That's going to promote or control herniation or swelling in there. Mannitol, what's that? Sugar water, right? We're going to give TXA as indicated to stop any kind of bleeding. We will give anticonvulsants such as Keppra prophylactically, so as to prevent a seizure there. And we might give hypertonic saline once again to control the pressure in the brain. Therapeutic hypothermia may or may not be considered. This is kind of falling out of favor based on a big study that occurred a couple of years ago that said that there wasn't really as great a benefit in the outcomes when we did do a therapeutic hypothermia. So what do we do with therapeutic hypothermia? We're just going to give that patient, a fighting chance of returning to a neuro function that they had before by cooling them down. Like I said, falling out of favor. Haven't done that in a while. And then obviously we're going to use our reevaluation adjuncts such as a CT scan that's going to really show our hematomas are bleeding. Those will light right up. MRI is going to kind of show us any tissue issues, so any kind of edema or any kind of diffuse injury. An angiography is going to obviously show us if there's any kind of vascular injury, and the patient might also get a skull series as well, so x-ray there. And laboratory studies that we should consider are going to be our coagulation studies to see if, you know, we were effective at controlling or reversing their coagulation medication. We're gonna check and see if there's any kind of alcohol or any other drugs involved as well. Monitor their ABGs. Lots of monitoring that needs to get done with these guys. Okay, and then obviously we're gonna go right into that reevaluation. Keep reevaluating the patient, and then the post-concussive care. We would obviously alert the physician for any kind of signs of changes in the neurological assessment. So we're going to be doing those serial neuro assessments. Note any pupillary changes. So a complete neuro assessment, now that you know how to do it. Keep monitoring their ABGs to show the effectiveness of the ventilation there, and make sure that the patient hasn't become acidotic. And then we're going to prepare, you know, that patient for any surgery or transport to the trauma center. Going right into neck, and I should really say neck and spinal cord injuries, because we're going to go through both of those there. And I really shortened this down because, you know, there's just so much to cover. So I'm just going to give you sort of the basics for this one. So mechanisms of injury of our, you know, neck injuries are going to be oftentimes blunt or penetrating. They're going to occur from acceleration or deceleration forces. Hyperextension occurs, you know, when we have that backward thrust of the head. Our hyperflexion occurs when we have that forward thrust of the head. A rotational injury looks like a forward flexion, and then the patient is going to be laterally rotated there. And then axial loading occurs vertically along that vertebral column. So really think, you know, the person that jumped into the water of unknown depth there. What we're looking at here is a dislocation. That's a big one, right? And that's the C7T1 area. And this is from an axial loading injury sustained from a tackle during a football game. Yikes. So, you know, the patients are always, or, you know, the football players are always taught to, you know, tackle head down. You know, this is something that can occur. So as you go out through the world and look at mechanisms of injury, you can see how things, you know, can occur. So injuries of, you know, the neck and the spinal area there, 55 or greater, you know, percentage are going to be from cervical injuries. And that's just because of our anatomy, right? Our head or our neck area is much less protected than our trunks that are, you know, protecting our thorax, our thoracolumnar and a lumbosacral junction. So concurrent injuries, so you need to consider other injuries at the same time. These can be like our closed head injuries, our long bone fractures, thoracic injuries, abdominal injuries. Just depends on, you know, the mechanism of injury, right? We can have our fractures and our dislocations. We can have a transverse or a spinous process fracture or dislocation that can occur right, you know, at the vertebral column, where there's chips off or can be damaged, you know, at that vertebral site, the posterior vertebral site. Then our wedge fractures, those occur from usually kind of a hyperflexion type of injury, and that will actually, you know, cause this like wedge looking area within that anterior portion of the spine there. Our comminuted or burst fractures, you know, we're going to have complete fractures, right? It's going to be like the shattering of a spine. And then our dislocation, which we saw in the previous slide there. Okay, so our spinal cord, we can have an injury to the spinal cord, and those vary in severity, obviously. We can have our concussions, of our spinal cord, and the effects of that are transient. They only last for about 24 or 48 hours. We can have a contusion of our spinal cord or bruising, and then a transection, which is going to be obviously very, very detrimental to that patient. Anywhere below the site, they're not going to be having any filling or movement, and this is a permanent thing. And then an incomplete transection, which is an interruption in vascular perfusion, and if that is not treated appropriately, then we can have ischemia, necrosis, and permanent disability. Okay, so we classify our injuries based on several things: the level of injury, so where on the spine it occurred, how much of a neurodeficit the patient has, and if there's any kind of spinal cord syndromes involved, and then the morphology in here, I'll just read this. Classifications based on spinal cord morphology are described as transection, compression, or laceration injuries. Vertebral injury morphology is described as fracture, fracture dislocations, spinal cord injury without radiographic abnormality, and penetrating injuries. And they can be further classified as stable or unstable. And with our spinal cord, as you can see here, it's very not unlike our brain, where we'll have our primary mechanical injury, whether it be a compression, a contusion, or involving the bone there, fracture dislocation there. And then obvious secondary injuries as a result. So here's our complete spinal cord syndrome, which is going to be a loss of all sensory and motor function below that level of the injury. Because of this, a patient's going to have, loss of autonomic nervous system function. So those things that our body naturally does without us thinking, we are going to have a difficulty doing, including breathing, depending on where on the body that is. So a patient may never be, has an opportunity to never breathe independently without aid of a ventilator there. They might have that poikilothermia, or like the inability to thermoregulate there, and priapism. You might notice based on that sympathetic neurosystem deficit there. And then, just like I had said, that patient might have some respiratory depression as well. Okay, a couple of things that can happen within our spinal system if we do have an injury to it, and these can include a neurogenic or a spinal shock. A couple of variations that you need to know about this: that neurogenic shock can happen at areas T6 or above there. Spinal shock can really occur at any level. With a neurogenic shock, the patient will have a temporary loss of that sympathetic tone, and with the spinal shock, they might have loss of reflex function that below that level of injury there. Duration of the neuroshock is temporary, and it's often less than 72 hours. So, one can hope that is the case if there's like an incomplete transection or something like that, and they're kind of monitoring that. Hopefully we're getting our function back within 72 hours. And then spinal shock duration can be quite variable. So even weeks, the patient may not have, their complete functioning, but all hope is not lost if they do indeed have that spinal shock there. Signs and symptoms of each of these, the signs and symptoms of a neurogenic shock might include all of these autonomic nervous system issues, hypotension, bradycardia, loss of ability to sweat below the level of the injury. And then with that spinal shock, the patient might exhibit signs of flaccidity or loss, definitely loss of reflexes if they do have flaccidity. Nursing interventions for this patient is going to be key, how we treat these guys. So we're going to maintain that C-spine, and we're going to log roll per policy. When we do our log rolls, the person that has that C-spine stabilized in their hands is going to be the one that directs everybody for that log roll. We're going to potentially give this patient a pressor, like a vasopressin or a epinephrine, something like that, to increase that vascular tonicity, if it was lost with that sympathetic tone there. And then we're going to do frequent neuro checks, obviously alert the patient or the physician to any kind of changes there. Lots of various ways we can keep that C-spine in order depending on what's going on with that patient. Oftentimes they'll come in with something that's going to be disposable but hard, and the patients really hate this one. This is that one on the left lower corner there. That's going to be our disposable C-collar there. The right, you guys might see that oftentimes on the surgical floor if somebody's had a fusion or something like that. That one's called an Aspen collar. And then we have the ability up in our top left hand corner to provide traction for that patient with like external fixation devices. And then same thing in that, lower middle area. Might have a little halo or something like that, an external fixator that's going to keep that C-spine intact. Okay, moving on to chest injuries. We have our rib and sternal fractures. These can happen quite readily for these patients. Lots of various ways they can get these, but the mechanism of injury is blunt for these guys. So they get kicked by cows or horses or thrown, into something. So many different ways that I've seen a rib fracture take place, including, getting arrested, things like that. So with the rib fracture, you might also see a sternal fracture. There might also be some underlying issues based on these fractures, so all of a sudden our ribs become penetrating objects within our thoracic cavity or abdominal cavity, really, and the patient might have some brachial plexus or some kind of thoracic outlet vascular injury. They might have liver, spleen injuries based on these rib fractures, or even lung contusions or lacerations. So once again, I go back to, consider that mechanism of injury for these patients. Assessment findings for these guys are going to be pretty typical. You're going to see some dyspnea, so some difficulty breathing. This patient has a collarbone fracture too. They might have pain associated with that, and in fact, there's usually a lot of pain associated with this. That you might notice a obvious kind of deformity, or you might feel bony crepitus. So when you kind of run your fingers into that area, you might kind of feel the crackle there. And there might be, chest wall contusions, a seatbelt sign or some kind of bruising on the external area. And so our interventions, in the meantime for these guys, because they're in a lot of pain or due to what's going on underlying, they might have, some structural issues with their lungs, which we'll get into, but you might have to provide some supplemental oxygen. So they're with pain, they're not going to be breathing as deeply as they would otherwise because it hurts. We're going to be pretty liberal with our analgesics with medicine, although not so liberal that it's going to decrease their respirations because we still want them to breathe. Obviously, we're going to assess for any of those underlying injuries. And then teach this patient how to use the incentive spirometer. Like I said, they're not going to want to breathe, but if they don't take those big deep breaths, then they're not clearing the base of their lungs. We're going to get atelectasis, and there might be potential for pneumonia. So gosh, if it hurts to breathe and cough now, imagine if the patient had pneumonia. So that's, kind of one of the spiels I always give the patients. It's like, I know this hurts, but you do not want pneumonia. And I've actually seen it. It's just miserable. Oh my goodness. Okay, so flail chest, this is pretty rare occurrence, but it can happen, and it's just really unusual. And this is more than one or two or more fractures on three or more, congruent or adjacent ribs, and or sternal fractures. So they're going to be at two or more different sites on three or more ribs. So lots of fractures is what's going to go on. And it actually can happen, with really anything. A couple that I've seen have been like ejections from vehicles, motorcycle accidents, things like that, that where you're going to get like that really hard blunt force injury there. Assessment findings are really unique to this type of injury, or the flail chest injury, and you're going to get a paradoxical movement. I have uploaded a link to a YouTube video that shows that paradoxical movement in these patients. And because of this, they're just not going to be able to effectively ventilate, and then obviously dyspnea will come from that. So interventions for these guys is going to be obviously be providing oxygen, but we're going to prepare to intubate. We're going to support that patient with some effective ventilation there. So we're going to give them their own airway there. And I just wanted to show you how good we've been in the, now compared to the past. It's just so disturbing sometimes to see these barbaric things that we've done to patients in the past. And I hope really in 50 years, I could say, boy, think about all the barbaric things that I did, and how medicine has gotten so much better. But this is an external fixator for that patient with the flail chest, so they can be able to effectively breathe on their own. Yikes. Okay, so I want to talk about pneumothorax. These can be simple or open. So a simple pneumothorax occurs when air escapes from an injured lung into that pleural space. Open pneumothorax, by comparison, occurs when air enters the pleural space through a penetrating wound. So simple, blunt trauma, and the open pneumothorax can be due to a penetrating wound. In either regard, there's going to be that nice negative interpleural pressure that's keeping our lungs nice and open is going to be lost, and that will result in a partial or a complete collapse of that lung there. So assessment findings for these guys, they're going to have decreased or even absent breath sounds based on, the level of severity that they have on that lung there. They'll have dyspnea, tachycardia, tachypnea, so fast breathing, fast heart rate, to compensate there. They might have subcutaneous emphysema, and they could even have subcutaneous emphysema within their neck if it was a simple pneumothorax. Sometimes you'll see that subcutaneous tissue kind of settle in their neck, so you feel their neck, and you can kind of feel Rice Krispies there. And then with that open there, the patient might have a sucking chest wound. So intervention for that simple pneumothorax is going to be really easy. They need to get a chest tube right away or as soon as possible. If it's small, sometimes they monitor those. So it kind of just depends on the level of severity there. The open ones, my mom told me a story about when she was a playground aide, when I was a kid, and there was a kid that had a pencil in his pocket and fell down and ended up with this little open pneumothorax, and she stuck her finger in the hole because that's all she knew how to do. But she did a pretty good job for, thinking on the fly. But the slightly more definitive treatment for that, for us nurses, or if you guys see this happening out in, the public, you need to create a three-way cover for these patients. So you're going to put a piece of tape on the top of a non-porous dressing and on either side of a non-porous dressing, and then leave the bottom open, and this can allow air to escape but not allow air to enter. And sometimes this can just be make matters worse, but most of the time it's actually helpful. So you need to really monitor these patients if you do that covering area there. Obviously, if there's like a tension pneumothorax, you're going to remove that dressing right away. And then, even more definitive treatment for that open pneumothorax is going to be a chest tube there. So we're going to get that negative pressure back and hopefully reinflate that lung there. Tension pneumothorax happens when the level of severity of that pneumothorax is so big that it affects all of the structures around it. And this is obviously life-threatening for those of you guys that took advanced cardiac life support last quarter. That was one of, your H's and T's. So one of those things that is going to be fatal unless you do something with it right away. The patient is going to be in severe respiratory distress, and you won't hear a thing on that injured side there. They will have probably quite severe hypotension, distension of the neck, head, and upper extremity veins. The late signs of this are going to be our tracheal deviation or our signs of cyanosis, So what happens there is that, with each breath that the patient takes, there's more pressure, and then it leads to this, what do they call it, a mediastinal shift to the uninjured side there. It compresses the heart, compresses the great vessels, and then it also compresses that other lung there. As you can see here, the heart's not supposed to be on the right side of the pleural cavity there. One of the quick and dirty things we could do for a tension pneumothorax, it will be an immediate needle decompression. There are some controversies, although I'm going to show you kind of the more tried and true location for this, but some people say it's actually kind of more along the fifth intercostal space at that midclavicular line, or a little bit more lateral there. So really we're trying to miss all of the other structures and allow air to escape as soon as possible. So this is something that we do quickly if we suspect this. So basically you'll take an IV needle and a big one, usually 14 or 16 gauge. I've even seen these occur with 18 gauge needles if that's all you have. You're going to go into that second intercostal space, midclavicular line, and then you're going to press the safety button, and you'll end up with the catheter stuck in that area there. Like I said, that's the quick and dirty thing that we can do, and then obviously the more definitive treatment for that one is going to be that chest tube for the patient there. So hemothorax looks actually kind of fairly similar to a pneumothorax, except instead of air, we're dealing with blood. Mechanism of injury for these guys is going to be blunt or penetrating. Blunt trauma can actually cause rib fractures, which, like I said, those become little lances in our body, and that can cause all these internal injuries, one of which can be the hemothorax there. So lots of bleeding can occur in a whole bunch of different areas that affects this. So we're looking at our pleural cavity. So if we could think of all the things that are involved with that, we have our lungs, but we also have our costal blood vessels, the great vessels, our aorta and our vena cava area, any other structures. And then we can actually get the blood in the pleural cavity due to a liver or splenic or even diaphragm injury there. Patient's going to have very similar features to that pneumothorax. They're going to have dyspnea and tachypnea. They will likely have chest pain. They might exhibit signs of shock. There might be some decreased breath sounds on that injured side there. And then we're going to prepare for the chest tube. And instead of, lots of air that's going to be coming out, we're going to be seeing lots of blood that's going to be coming out, right? Then we have our pulmonary contusions. These are our bruises to our pulmonic area there. This can occur from a direct blunt, likely occur from the direct blunt, and you might not see the complete effects of these right away. They can develop over time. Assessment findings for these guys are going to be our dyspnea or increased work of breathing. They might have an ineffective cough, and they might have hypoxia, chest pain. You will see possibly some bruising or abrasion on that chest wall there. So a couple of things that we need to know with these guys. Interventions, we're going to maintain that SpO2, between 95 and 98%. We don't assume hypovolemic shock on everybody that comes our way. So we really need to be careful with giving these particular patients IV fluids, because fluid overload can be a real big problem for this patient and actually exacerbate any kind of pulmonary edema that they might have. And then we will most likely, or there's a high probability that we'll intubate and ventilate this patient as well. What you're seeing right here is a right-sided pulmonary contusion. Blunt cardiac injury, just like with any part of us, our heart can be involved in an injury, and this typically occurs with this direct impact to the chest. So oftentimes, what happens in like a motor vehicle accident, the car stops and then we continue to move forward and hit that steering wheel, and then our heart continues to move forward after we have stopped, and that shearing kind of injury can lacerate these great vessels that we've got there. So lots of obvious things can happen with this, including EKG abnormalities. You might see chest wall ecchymosis with this, and the patient is likely to exhibit some chest pain there. So interventions for this one, we're obviously going to treat their heart rate and rhythm, and treat any kind of dysrhythmias. And I think I kind of stopped here because I sort of went into this aortic disruption. Forgive me, I'm going to skip a slide so we can talk about this all at the same time. So once again, this can happen, just like I described, except assessment findings of this are going to be fractures of the sternum, clavicle, scapula, you might see in addition to, and you might notice a cardiac murmur, definitely some hemodynamic instability if we're going to have this aortic disruption, so that our aorta is going to be involved. You might see some unequal extremity, pulse strength or blood pressure, and when you do that, you're going to note like some really weak pulses on the Let me gather myself here. Okay, so the blood pressure is going to be significantly higher in the upper extremities as opposed to our lower extremities for our aortic disruption, which I described in the last slide. And the interventions for this are going to be our mass transfusion. Obviously, we're going to be losing a ton of blood here, so we need to replace that blood as at even as faster rate as the patient's losing that, and ultimately they'll have a surgical repair. So going back to this blunt cardiac injury, which is not as significant as our aortic disruption there, we're going to monitor our heart rate and rhythm, and then treat any kind of dysrhythmias. Excuse me, boy, skipping on my own slides. Okay, so let me go to the cardiac tamponade here. Our definition of this is a collection of blood in the pericardial sac, and this can oftentimes be caused from our penetrating traumas, but if we think beyond our penetrating traumas, this can happen at like end-stage cancers and all sorts of things. So cardiac tamponade, you'll see that really readily on the radiologic findings on the chest x-ray there. The heart will just look a lot different than it normally does, kind of have a rounder shape appearance there. The assessment findings are of this cardiac tamponade. You will note this Beck triad, or Beck's triad is what they call it, and this is a muffled heart, hypotension, and distended neck veins, and those three things will give you a clue that this is a cardiac tamponade. The patient might also have chest pain, various different kinds of electrical conductivity issues in the heart, including like a tachycardia, or they might even have, PEA or pulseless electrical activity there. The patient will likely have dyspnea, cyanosis, so really, really ineffective perfusion for these guys. And then pulsus paradoxus. And with pulsus paradoxus, during that inspiration, you'll note that the pulse becomes very, very weakened or super thready there. And there will be a blood pressure on inspiration that drops more than 10 millimeters of mercury. And like I said, that's during inspiration there. Interventions for this is going to be something called a needle pericardiocentesis. What happens with this is the provider grabs an ultrasound machine and uses the ultrasound and guides the needle into that pericardial sac there, and then removes the fluid, aka blood. All right, we already talked about this slide, moving right along. The patient does have potential also to have a ruptured diaphragm, and I really wish I have seen this, but I have not. So I'm only going on what I can gather in my research here. A patient will have a herniation of abdominal contents into that chest cavity. So if we think about, what the diaphragm does on our daily basis, it's going to, keep our abdominal contents down into our abdomen, our stomach, our intestines. This picture right here, all that black stuff over on the right side or the patient's left side of the chest there is intestine. So this can occur from a blunt or a penetrating trauma. Assessment findings of this is going to be dysphagia, or difficulty swallowing, abdominal pain. You can hear bowel sounds where the lung fields should be. The patient might have sharp epigastric pain that radiates to the left shoulder due to that irritation of the diaphragm there. The Kerr sign that we've all know about, and the patient might have decreased breath sounds on the injured side. And then intervention for these guys is going to be prepare for some immediate type of surgery there. We should know what is occurring when we use our chest drain systems there. So are we taking care of a pneumo or a hemothorax? With our pneumothorax, we're going to expect more, air control. With our hemothorax, we're going to be getting rid of blood. The patient or the physician should, however, be notified if the initial output of that chest tube drainage is greater than 500. That's a half a liter, right? That's a lot. Oh, or if there's more than 200 milliliters an hour for 2 to 4 hours, the physician should be notified. And then we should not be clamping that chest tube. So abdominal and pelvic trauma, mechanism of injury for these guys, it's going to be our blunt force trauma. So we'll have those solid organs that might lacerate, like our spleen and our liver, or the hollow organs rupture. So our hollow organs, like our stomach, our bladder and whatnot, can actually rupture. Mortality rate for these guys is pretty high, 10 to 30%. And as far as pelvic fractures are concerned, they're very, very common after a fall, and lots of bleeding occurs. The patient can be quite hypovolemic quite quickly, and it carries with it a 20% mortality rate. So the patient's just not out of the woods with a pelvic type fracture. Penetrating injuries, as we can see here, can occur from just about anything, but also include, our gunshot wounds, our stab wounds, and our blast injuries. We should note everything around these when we think about our mechanisms of injury, including any kind of associated hemorrhage. We should consider the aorta, the thorax, diaphragm, consider rib fractures and what that's doing to the underlying structures. We should consider, with our pelvic fractures, any kind of underlying organ injuries with that. And then the patient with the potential mechanism of injury might have lower extremity fractures as well. All right, the patient with any kind of abdominal injury may have pain associated with it. They might have tenderness, guarding. Lots of irritation can occur at that peritoneal membrane. And this is due to things like injured pancreas, that causes some spilling into the peritoneal cavity, can lead to inflammation, necrosis, and even tissue death. So we should be aware of that. The Kerr sign, the patient might have referred pain, such as a Kerr sign. So irritation of the undersurface of the diaphragm that results in pain being referred along that phrenic nerve, and that goes right into the left shoulder. So when we have that left shoulder pain, that's that Kerr's pain, right? And pain may be referred from one quadrant of the abdomen to another during palpation. So even if we consider, our appendicitis type patients, they're going to have likely a referred pain. It usually starts at the belly button, but they can have pain in that left lower quadrant. So we should consider that pain may be like a referred type pain. That's what that is. But wherever the patient says that they're having pain, we should start our abdominal palpation away from that and focus on the area where there's the most pain, the very last. Our liver has a potential of getting injured quite readily, especially with like our motor vehicle accidents or a blunt force trauma. This can create hematomas, so bleeding may be contained by the capsule that encases the liver, and it results in a hematoma, or the patient may have a laceration. So the capsule where within the liver may be affected and create a laceration. These hepatic injuries are graded from grade 1, which is the most mild, to grade 6, which is the most severe. And the treatment for these can include a tube to alleviate some of the pressure from the bleeding, or some kind of laceration repair, or I've seen even in like the more mild grades, grade 1 or 2, the patient may or may not have surgery, but they're definitely going to be observed in the hospital. With these, the patient might exhibit some tenderness or some guarding or even some rigidity in that right upper quadrant of the abdomen. You might see some lower right rib fractures with this, and the patient, if there's any kind of retroperitoneal bleeding, or peritoneal bleeding, I should say, might have that colon sign. Colon, I always think colon and center, so think of the center of your body, which is right at the umbilicus there. So they'll have ecchymosis at that umbilical site there. And like I said, there we're going to control any kind of hemorrhage, and we may or may not operate on these individuals. Splenic injury is the most frequent injured organ that's caused from blunt trauma. So our spleen, if we should, any kind of blunt trauma, we should carry a high level of suspicion that there might be some splenic involvement with there. And once again, the patient may have a hematoma or a laceration of that spleen. And, it's likely to happen left-sided impact. And so if we can kind of think of where our seatbelt lies, these really oftentimes happen with any kind of blunt trauma, but especially our motor vehicle collisions. And as opposed to the liver, which is graded in severity from 1 to 6, the spleen is graded in severity from 1 through 5. Our spleens, as you guys know through your anatomy and physiology, are highly vascularized. So any kind of bleeding or injury to that spleen may cause a lot of bleeding. So we're going to control that hemorrhage as much as possible. Assessment findings for these guys are going to be, anything that's associated with a left upper quadrant injury. The patient will state tenderness. They might have hypoactive or even absent bowel sounds. You will notice on your palpation some rigidity, or the patient might have some guarding. Or hemoperitoneum, which is that localized fluid collection right around the spleen there. So definitive treatment for these, we're going to obviously control the hemorrhage. If we need to give the patient back some blood, we will give them some blood to reduce their hypovolemia there, or to manage their hypovolemia there. And once again, we can do a watchful waiting with these patients, or they can go right to the operating room depending on the level of severity there. So the non-operative, we're just going to continue to monitor them because, like I said, highly vascular, and we need to make sure that that's not scarier than we thought it was initially. For the same reasons, we can have a pancreatic injury. These are going to be a lot less, if we think about things structurally, a lot less often than our splenic and our hepatic lacerations and injuries, and that's just because of where the pancreas lies structurally there. Assessment findings of these are going to be fairly similar. The patient's going to have pain. It's likely going to be epigastric pain. You might also notice some rigidity or some abdominal wall spasm, or the patient might have some guarding. Guarding just really means that it's localized right at that site there. They may have increased amylase levels. Anytime we have any kind of injury to that pancreas, our amylase is going to show us that that's going on. And definitive care for these guys is going to be likely non-operative. They're going to have bowel rest, so we're not going to feed them. They'll be NPO, and they may have a percutaneous drainage as well. Our small bowel has a potential of creating an injury. These can result in ruptures, hematomas, tearing type injuries, or can occur due to any kind of chance fractures. And this is our tubes rupture and our cubes lacerate. So our small bowel is a tube, right? So it has a higher likelihood of rupturing there. With this, you might notice some seatbelt signs, kind of bruising externally for the patient. They'll likely have some rebound tenderness, and they might even show signs of like a muscle spasm or rigidity in the epigastric area or the left upper quadrant of the abdomen. And this is what a seatbelt sign looks like. And as you can see, when a person has a motor vehicle collision, we need to recognize all of the underlying structures. But yeah, just think about where your seatbelt is and what can be injured from that. Large bowel injury. Mechanism of injury can be blunt or penetrating. The blunt is going to be, the more common one, and the patient or the bowel may rupture, tear, or even avulse there. With that, the patient will have peritoneal irritation, likely, because this is a large structure, large vascularization going on there. They may have some hypovolemic shock there, and the bowel can even eviscerate or, end up externally. Definitive treatment for our large bowel injuries are going to be a primary repair or even a diverting colostomy, where they'll give the rest of the bowel some rest while that heals there. Pelvic fracture, your table 12.6 and IGGI shows lots of different primary injuries or patterns of injuries that can lead to pelvic fractures, such as lateral compression, anterior posterior compression, or vertical shearing there. So we have stable pelvic fracture and unstable pelvic fracture. Our stable pelvic fracture, there's going to be minimal or no displacement of the pelvic ring. You won't be able to really feel it during your assessment when you do your secondary assessment on this patient during your head to toe assessment. Unstable pelvic fracture, there's going to be 2 or more fractures of the pelvic ring, and there's going to be some obvious displacement of the leg that will be rotated, and there will be it'll be nice and displaced there. And with this unstable pelvic fracture comes with it a massive risk for hemorrhaging. So we need to get the binder on these patients right away, or whatever kind of fixation that we're going to be doing. Just like I said, you'll see that leg being kind of externally rotated out. During your head to toe assessment, you might notice some blood at the meatus of the female or male urethra. The patient will have pelvic instability, and like I said, lots and lots of bleeding really fast can occur, so the patient is likely to experience some hypovolemic shock, so we need to be prepared to give that patient back some blood there. So various different things that we could do to control the hemorrhage there. We can use this on the left side. That's a pelvic binder. It goes a lot lower than most people think, so it goes at the hip, not at the waist. But you just get that and put it as tight as possible. one of your peers will be able to show you what that looks like, and our tools of the trade assignment there. And then as quickly as possible, we're going to want to either externally or internally stabilize that pelvis. What you're looking at here are some external fixators of the pelvis that's going to, stabilize it. This right here is called an open book pelvic fracture, and in this case, both of our legs are going to be kind of externally rotated. And if you were to do an assessment on this patient, which I would highly encourage you not to, because you can really wreak havoc in there. Instead of just putting that binder on, if you chose to do an assessment, you can they call it open book pelvic fracture, because you literally can take the hip in your hand and open the book. It'll be very, very, very unstable. So we just need to get those binders on those guys. Okay, we can have a potential to experience a renal injury. These are graded 1 through 5 in level of severity. If we notice any kind of blunt flank trauma, we should have a high level of suspicion with these, along with our deceleration injuries, and really our falls from heights. So we should kind of be aware that there might be a renal injury based on that. Penetrating traumas to the flank or pelvis can carry with it a high level of suspicion for a renal injury, and that's what this picture demonstrates. This is actually a gunshot wound right into the kidney. Assessment findings for these guys: you might notice some bleeding in the urine there. We might note a CVA tenderness, elevated BUN and creatinine there. Their kidney function's not going to look all that great. An IVP is an intravenous pyelogram, which is going to be a contrast study, CT scan, or a pyelogram, I guess is what it is. And it'll show a leakage of that contrast. So when you add that contrast in, it's going to show some leakage. Interventional radiology can also be involved with this, and perform an angiography, which will kind of show the same thing, the leaking of fluids through that angiography. So 90% of these are actually non-surgical, and we just kind of do a watchful wait on there. We do have 2 kidneys. The patient is going to get a nephrology consult, and there is actually a potential for some surgical repair, just depending on the severity there. All right, I want to tell you a little bit about the FAST exam, is what they'll call it. A FAST exam is performed by a emergency provider. It's called the Focused Assessment with Sonography for Trauma, and we use these a lot, and these will show us a lot of things very cheap and very quickly. We use a portable ultrasound. It has excellent sensitivity. So advantages of using ultrasound to check for any bleeding in the peritoneum are going to be that we're not using any radiation, right? And that's good, and it's very non-invasive there. Some limitations with this one, it's going to be not as sensitive. If there's smaller volumes of blood, the larger volumes of blood, they're going to kind of be able to catch right away. And the provider might have to do serial examinations, so look and then look again to see, if the bleeding has expanded there. And it will not identify any kind of retroperitoneal bleed or bleeding, that happens behind the peritoneal area there. And then it requires a competency level. So some of, our older physicians haven't quite caught on, but really, by this stage of the game, most of them are pretty good at, the POCUS, the point of care ultrasound with their fast exams there. They can, like I said, quick, cheap, and you'll be able to get some information right away. A patient might also have a diagnostic peritoneal aspiration or a diagnostic peritoneal lavage. This happens with our hemodynamically unstable patients. And what happens here is we insert a tube and do a lavage or add some fluid and then aspirate. We just add saline and then aspirate. And so if the aspirate shows any bleeding, then we can suspect that there's bleeding in that peritoneal area. The sensitivity to this is nearly 100%. It doesn't show limitations of this. It doesn't really show the site, and it's really invasive. And I only laugh at this because this never happens. Nobody ever uses diagnostic peritoneal lavage because the doctors have gotten so good at doing those fast exams. But for the longest time, the American College of Emergency Physicians says that a provider needs to be competent in diagnostic peritoneal lavage, prior to graduation or to them being able to be on their own. So this used to happen quite a bit, but never happens anymore. But we should know that these things exist, right? So nursing care considerations for any kind of diagnostic procedures. So if a patient's going to have an angiography, we need to prepare the patient for transport to that interventional radiology site, wherever that might be. While they're there, we're going to monitor the hemodynamics, and as they add contrast, we need to monitor for any adverse reactions to that contrast there. And then after the procedure, whether the insertion site was in the femoral artery or in the radial artery, we need to monitor that access site there. So with the FAST exam, the nurse needs to know that a distended bladder causes a higher sensitivity for the physician. So we should perform the FAST exam and then do the urinary catheterization if the patient needs urinary catheterization. So consider that as you prepare the patient for urinary catheterization, that the provider will likely want to do the FAST exam first. CT scan, we're going nursing considerations for that. The patient might have oral contrast. We need to monitor for any aspiration if they do have oral contrast. Take that patient to the CT scanner and be with them the entire time. We're going to assess, level of consciousness, and if the patient does have some kidney issue, if they're on metformin, if they have any kind of long-term kidney issue, then we should be giving them fluids, lots of fluids, because the CT contrast can really wreak havoc on our kidneys there. And then the diagnostic peritoneal aspirate and lavage there, as opposed to our FAST exam where we want the bladder to be full. In this case, you will want the bladder to be empty, as to not hit that when you're doing the peritoneal lavage there. And we might consider also placing an NG or an OG tube to decompress the stomach as well. So, orthopedic trauma. We'll go into a few of these. Our mechanism of injury here can be from a single site or any like multi-system injuries, and these are distracting injuries as we go into our trauma. So a patient, has a obvious like open, tib fib fracture or something like that. It's hard not to look beyond that and think about what might be happening underneath. They're really great distraction injuries. So just keep that in mind. If you're going into a trauma there. They can occur from falls, motor vehicle collisions, assaults, sports activities, work-related activities, home-related activities. I've seen it all. The roller skating arena, all of that stuff. With our orthopedic injuries, we can have fractures, dislocations, amputations, sprains, ligamental tears, tendon lacerations, and the patient might have some neurovascular compromise due to any one of these. Pathophysiology of these guys, you're going to potentially see some blood loss. This occurs when there's a disruption of anything in our vascular system, right? Our arteries, veins, our capillaries there. The hemorrhage can be on the inside once again or on the outside, so we should make note of that and then control any kind of hemorrhage for that patient there. They might have some nerve injuries associated with these fractures, like an interruption of the conduction pathways. They might have an altered pain sensation, so we think that they should be in a lot of pain. They really aren't. We kind of need to be suspicious that there might be some nerve involvement there. The patient may have an impairment of any motor or sensory functioning distal to the injury site, and there might be some cellular hypoxia. I won't go too far into this because I've already spent, looks like an hour and a half, but there are various fractures that can occur, and you guys should just be aware of these. So look at the slide and take note of it, and definitely if you're going to be an emergency department nurse or work with pediatrics or something like that, you should be aware of what these fractures do, and I've written some notes on the slide pages, so just be aware of those. With our femur fracture, this is one of our long bones, and it once again can really wreak havoc anytime we have any kind of large bone fracture, like our pelvic fracture or our long bone fractures. We're at risk of losing a lot of blood, so we need to be aware of any kind of hypovolemic shock for this patient. Other assessment findings for them are going to be pain, obviously, inability to bear weight. They might have a shortening of the affected leg there. You will see this oftentimes in the elderly. They call them, grandma broke her hip. Well, in this case, it's not the hip, it's the proximal femur is what is actually injured there. So the patient might have some shortening of that affected leg. They really will. It's very obvious when you see that patient as you walk into the room and remove their clothing that there's shortening of that leg, and then it's externally rotated there. The patient might also have edema or hypovolemic shock with this. The nursing interventions we need to have for our hip fractures are going to be obviously control of pain. Sometimes, if someone, an elderly patient has this fracture, then, there's a higher likelihood that they're on an anticoagulant. And so, the patient needs like vitamin K or FFP, fresh frozen plasma, before they have surgery. Then we really need to consider all the pain control for this patient, and then obviously monitor their vital signs quite readily. We can sort of raise that leg a little bit to splint it, depending on what the orthopedist wants us to do. But you can oftentimes see a pillow under that, and that'll help with maintaining vascularization for that patient as well. Okay, we have our open fractures. This occurs from an open wound. With this, you will note a protrusion of the bone. The patient is likely to have pain, and there is likely to be neurovascular compromise. So we need to monitor these patients' CSM, right? Circulation, sensation, movement. Can you wiggle your toes? Can I feel these pedal pulses distal to the injury site? So we're continuously monitoring that, and if it's compromised, then we need to note that too. The patient does have a high risk of osteomyelitis, so infection of the bone based on this, and even sepsis. So we need to get this patient a Tdap shot, right? And 2, or if they're under 8, a DTaP shot. And 2, we also need to get them on an antibiotic right away. Okay, an amputation involves an obvious tissue loss. As you can see here, this is the amputation of the forearm there. The patient may or may not have bleeding, depending on neurovascularly what's going on with them. And then the bleeding may be severe or controlled. You should know that with a complete amputation, like it is existing in this picture, the bleeding is oftentimes less, and with our partial amputations, you'll have a lot of bleeding, and this is due to how quickly the vasculature got disrupted. They're able to because of our inflammatory process when we heal, they're able to send a clot right away, and our body is able to send a clot right away, and we may be bleeding less with that. So the patient, obviously, if there is a mass amount of bleeding, there might be a potential for hypovolemic shock for these guys. So our priority for the patient, we're going to do a primary assessment and identify any kind of life threats that can come first, right? It's always CABC. And then we're going to kind of control that existing hemorrhage. Tourniquets may be applied to if there's any uncontrolled hemorrhaging there. We can control bleeding with direct pressure. We can elevate to take some of that pressure, away from the heart. So give the patient a fighting chance to reduce any kind of bleeding. Like I said, tourniquets, they have fallen in and out of favor a few times, I guess, since I've been a nurse. Right now they're back in. So we like to use tourniquets. And, obviously, if we're having uncontrolled bleeding, use that tourniquet. So with that residual limb, there is some nursing interventions that we need to do. So we'll remove any dirt or any debris on there. And then we're going to wrap that amputated part in some slightly moistened saline gauze. So take some saline and moisten it, and then we're going to wrap that amputated part. And then we're going to place the amputated part in a sealed bag. And then we're going to place it in a second bag that has ice. So we're not going to put direct ice on that amputated part. We're going to put it in a sealed bag within an ice bag. So a crush injury results from a prolonged compression, entrapment, or a crushing blow These injuries can result in serious complications when they affect a major muscle mass, like a thigh or a calf muscle. So we need to be aware of that. Muscle injuries lead to muscle ischemia and cell death, and that releases enzyme called myoglobin or protein myoglobin, and then other cellular components like potassium. So because of that, the patient might have high potassium, hyperkalemia, and with that release of the myoglobin, the patient might also have rhabdomyolysis. And rhabdomyolysis, some assessment findings of that, the patient's going to have dark red or brown urine. It'll be like tea-colored urine is what it looks like. And they might also tell you that they have a lot of muscle weakness or a lot of muscle pain. These are signs of rhabdo. If we pull a CK level on these patients and notice that it's like 5 times the normal limit, then the patient is most definitely in rhabdomyolysis. As you guys remember, the treatment for that is lots of fluids, and the patient can even go on dialysis. They can have quite an acute renal failure from this. And then compartment syndrome for our crush injuries, and we'll talk about compartment syndrome here in the next couple of slides here. Interventions for these guys, we're going to give them some IV crystalloids, or if there's some obvious hemorrhaging, we're going to be giving them some blood back. We will elevate the injury there and then monitor for any kind of cardiac arrhythmias that might be associated with all of that potassium that's now circulated in the blood, and then anticipate that the patient's going to be going to surgery. So really, with compartment syndrome, we can have elevated compartment pressures from an inside source, like a hemorrhage, edema, or a hematoma, or an outside source, like a cast, dressing, traction splints, or air splints. And so it can occur as a result of an internal or external source there. So with that, there will be an increase in pressure in the fascial compartments, and that inhibits the blood flow. So pressure in the fascial compartments, impaired blood flow, right? And because of this impaired blood flow, they may have some ischemia developing from that. And then more of the ischemia developing can cause more of that pressure in the fascial compartment, and all of a sudden we're in this terrible loop that we don't want to be in. Muscle death can occur within 4 to 6 hours, and that results in permanent loss of functioning. So we need to do something for this patient right away. Time equals tissue, right? So the quicker we can act on these for the patient, the better that the prognosis will be for the patient. So here's our different compartments or fascia there, which causes increased pressure from either an internal or external source, which leads to impaired blood flow, right? Which leads to ischemia. Okay, so with the compartment syndrome, they are going to have 6 P's, so it's going to be easy. So pain is going to be like that first one. So oftentimes the patient will be like trotting along with, a pain that's congruent to how you perceive things, and then all of a sudden the pain is just going to be explosive. So they'll be okay and then not all of the sudden, and with that you should have a high level of suspicion for compartment syndrome. You might notice some pressure. In fact, if you do a pressure reading on this patient, it will be markedly high there. But if you don't have, a manometer with you, you can just feel that limb. It's going to be nice and tight, firm to the touch, or tense there. You might notice some pallor, so some cool temperature, some pulses. So pulses can remain normal in the presence of compartment syndrome, or they may be decreased. You will notice that, but you'll also notice some delayed capillary refill there. So note the capillary refill as well. And then paresthesia. So the patient might have numbness, tingling, loss of sensation distal to the site there. And paralysis or motor dysfunction signifies an injury to the nervous system, obviously. So if it has come from an external source, that's usually iatrogenic, right? Something that we did. So we're going to remove that constriction right away. We will get that cast splint cutter out and cut the cast or remove the splint that the patient has. We're just going to remove that right away. And then in most cases we elevate above the heart, but here to decrease the pressure, we're going to elevate that limb to the level of the heart, not above the level of the heart. And then here is our compartment syndrome readings with a manometer. They might have a pressure of like even 30 to 40 millimeters of mercury. That's suggestive of ischemia. Normal pressure for these patients is 0 to 8 millimeters of mercury within these compartments. And then something that the surgeon or ER physician or provider might do is perform a fasciotomy, so a release of that pressure via a long superficial cut into the fascia that relieves that pressure there. Last slide, can you believe it? Okay, this is joint dislocations. Joint dislocation is going to be characterized by any inability to move that affected joint. The patient is going to have pain. They might have edema and any kind of abnormal range of motion. So in the case of this young fella here who has a jointless dislocation of his shoulder, he is not going to be able to move his shoulder independently. They may also have some vascular compromise because of a joint dislocation, and so we need to monitor this. Once again, the CSM, the circulation, sensation, and movement, anything distally to there, right? And so the treatment for this is going to be a reduction of that, and then we're going to immobilize it to allow it to heal on its own. And once we have a joint dislocation, the patient has a higher risk of having subsequent joint dislocation. So you can see in the emergency department these trends of people, seeing the same people or people saying, oh, this has happened to me, before. I know what's going on. Usually I could put it in myself, but today I can't. So you'll see that a lot. So after the patient has a reduction of that, prepare for an immobilization of that affected joint there. Oftentimes this happens under conscious sedation because of muscle spasm. The muscle is too rigid to get that reduced back into where it needs to go. So the patient will have conscious sedation. Little Versed, it's going to probably, no doubt, make those muscles a little bit more lax too, so you're able to reduce that. All right, so there we are.